Hello and welcome to our presentation on Histocyte Laboratories cell line controls. My name is Dave Prine and I'm the Technical Sales Manager at Newcomer Supply. And I would like to introduce you to the two people that will be leading us through this informative conversation. Colin Tristram is the CEO and co-founder of Histocyte Laboratories and has over 25 years experience in developing and commercializing products in the tissue diagnostics market. His product development work was instrumental for Histocyte Laboratories creating tissue-like controls for cell lines or from cell lines for the use in immunohistochemistry and in situ hybridization. Our other participant, Dr. Richard Cartun, has been involved in immunohistochemistry for over 45 years. He served as the director of histology and immunohistochemistry in the Department of Pathology and Laboratory Medicine at the Hartford Hospital in Connecticut. Many of you may recognize him from the numerous lectures he has presented over the years at the NSH conventions. I'm excited to start this discussion. And the first general question I have for you, Colin, is for labs that have been using tissue controls solely for years, what would you like them to know about cell line controls and how they may fit into their daily operations?
Well, thank you very much, Dave, for having me and Richard here today to talk about these things. In answer to your question, labs that are using tissue invariably have to hunt and gather the tissue from their archives or even extend the search beyond the hospital to find some of the materials that they need. And what we're looking at here in particular is quality control. So you're measuring the quality of the assays that are being produced in the laboratory. Tissue is obviously one good way of doing it, but it does have its flaws, which we'll probably talk to later on. But as an analyte control, the cell lines are standardized and should work in a given manner with particular assays. And so it gives them a reliable standard to really just assess that the assay has worked as they expect. And what we do is we produce blocks of this material, as well as slides. Some laboratories will use slides, but they tend to sample the slides. But they use blocks, and we provide blocks, and they fit far more smoothly into the workflow of those laboratories, where they can far easily adopt them rather maybe than having yet another fridge full of slides that they have to use. So they are a kind of an accompaniment to tissue for these laboratories, and really reduce the stress and the burden on the laboratory to try and find and manage those materials. So I think that's what I would say, and I suppose I would see if that rings for Richard in terms of what I've just said.
Thank you, Dave. Hello, everyone. Colin, it's great to be with you. I remember many years ago when you visited me at Hartford Hospital, and we welcomed you into our laboratory. It's been a long time, and even though we're thousands of miles away today, I feel like we're together in a room, which is great. It's been my observation that the availability of tissue in the surgical pathology laboratory has changed over the last 4 decades. I remember when I first started back in the 80s, it was not uncommon to see tumors that were very, very large, and there was so much tumor that we could harvest and fix and process and use for controls. In fact, I remember cases where we put through hundreds of tissue blocks, which I know are still present in the file at Hartford Hospital that we use for control purposes. But that's not the case anymore. And I think there are 2 reasons for that. And I'll ask you to speak to this as well. Number one, which is actually a wonderful, wonderful thing, the average size of many cancers today has decreased over the years, so much so that the entire sample is usually submitted for pathologic evaluation. And along those lines, best practices from different organizations, cancer committees, etc., now require that the entire specimen be submitted for pathologic evaluation, if that is possible. And I know it's possible because we were seeing it, and it resulted in a lot less tissue that we could harvest from our specimens for control purposes. Has that been your observation as well?
Yeah, I mean, I think I agree entirely with what you're saying, and you know, we now have laboratories telling us that, you know, it's a combination of things. You know, tumors are treated with, you know, various chemotherapies before they're resected, so you know, they don't necessarily reflect the you know, the original pathology, and samples are getting smaller, and with the advent of NGS, for example, you know, some samples, they need to preserve them. They can't use them because they need to see if they need to do any molecular work on them. So there's a whole combination of those things, as well as, you know, the fact that they're treating some very, you know, rare mutations. So a lot of labs don't actually have that material available, Richard. So yeah, I definitely I agree. I mean, pathology has changed, and as you say, it's great in many ways because it's reflecting, you know, the advances that we have in patient care, but it does make it difficult for laboratories. And even, I mean, you know, when I first met you and I was making antibodies, you know, it never used to be a problem to get hold of things like tonsil, for example. But, you know, that's become much more difficult. I don't know in the US, but here, certainly in the UK, you know, tonsillectomies, they tend to do that as a last resort, where, I mean, I remember growing up, most kids had a lot of kids have had their tonsils out, which meant there was an abundance of, you know, tonsil control material. But the labs now, they struggle for even some of the, you know, what we would have considered the more obtainable control material, Richard. So you're right, there's been so much change over the last, you know, 20, 40 years.
Well, good. Thank you for confirming my observations. I did have some samples that I did test in our laboratory, running our immunohistochemical platform and antibodies. And I have to say, I was very, very impressed. And what I think is really advantageous about some of these cell lines that you've developed is this so-called dynamic range of expression that you see. You know, I think most laboratories, they're looking for HER2 overexpression using immunohistochemistry. They use a 3+ positive control, which is great. But, you know, I think today for a control, you need to be looking at 2+ and 1+ and 0. That's very important to guide your interpretation of this very important biomarker that we do for breast cancer and other types of cancer today. So I think that really is a benefit of these cell lines, is that you do have different ranges of expression from what I've seen. Now, as a potential purchaser of these cell lines, I have a few questions that I would like to ask you. Number one, obviously pre-analytics are critically important to the performance of immunohistochemical testing. We know quite a bit has been written and published on fixation and histologic processing and its effect on immunoreactivity. Are these cell lines fixed in formalin, and are they processed just like a tissue specimen would be processed in the histology lab?
Yeah, so we part of the early phases of Histocyte was establishing a protocol that provided equivalence to tissue. So the cell lines are indeed fixed in formalin and processed in a tissue processor. There are some proprietary things that we do, but essentially the proof's in the pudding, Richard, as we say over here. The fact that, you know, we can use these standardized assays and they perform appropriately. So, you know, in the case of the HER2, we have 3210 scoring cell samples, and that's how we know that, you know, how we're fixing and processing them is equivalent to how the tissue works on the same slide.
Okay, thank you. So, do these cell lines do they work well using the same antigen retrieval that one would be using for their patient specimen?
Yeah, and importantly, I think one of the things about our cell lines is we talk about this kind of tissue-like essentially what we do is try and preserve the cell's original morphology. So when you look down a microscope at our cells, they don't look like, I would say, cell lines from other vendors, where, they look fairly fragile when you look down the microscope. We retain that morphology, and that's really critical because yourself, the morphology of the sample can tell you just how, let's say, badly treated they've been. If they've been over retrieved, you get disruption of morphology in the tissue, and the cells can show you that. So they're robust enough for the standard epitope retrievals used in the laboratories across multiple instruments, high temperature and pH. So they're robust enough, but the important thing is, you can see in the cells if perhaps that they're verging on potentially being over retrieved, because you can see changes in the morphology against what would be the norm. And yourself, with biopsy material, they can be quite fragile and prone to the same kind of rigors. So that's kind of what we pride ourselves on, is that we have this retained morphology. And so one of those parameters of quality control can be measured where, certainly from the cell lines that I've seen from other vendors, they don't look so healthy. And the giveaway is they kind of have a shrunken look about them, where ours, you can see they're quite whole and entire. And that's important as one of those QC measures.
My third question, and I think you may have already talked about it when you were answering Dave's question, but are these cell lines available? I know they're available as unstained slides, but are they also available as a paraffin block that a laboratory could purchase and then do their own microtomy, which might be important if they need the tissue placed in a specific area of the slide, depending on the automated IHC platform that they're using?
Yeah, exactly that. We provide blocks. They're probably more cost effective as well, I would say, Richard, in terms of cost per test. And yeah, you're right. There's a number of things at play. There's how they treat their slides, or the platforms that they use the slides with, and generally they should validate them in use in their laboratories. So I mean, even if they were to get tissue from another laboratory, they'd still need to validate it. And we say exactly the same thing with the cell lines. And in particular, they need to validate over a particular period of time. So they might cut those slides and store them. So they need to do that and validate in use. And that doesn't always happen. And I think there's an assumption, even when they buy cut slides, that they should be good. But, I know a lot of laboratory fridges, they don't necessarily maintain that temperature because they're open and closed all the time. So there's all these kind of environmental factors that being able to buy the block and validate it in use and use it as you would use your normal controls, I think is invaluable to fit it into your lab's workflow. So yeah, definitely blocks.
Okay, thank you. And my last question, which I already think I know the answer. Many laboratories in the United States, surgical pathology laboratories in the United States, have College of American Pathology, CAP certification or accreditation. Do you know whether these control cell lines are accepted as substitutes for tissue by the CAP?
I know, I think with Nordic QC, I think it was something over 10% of their participants submit cell lines, and they're just they're scored and accepted as, if the staining is appropriate, of course, they're accepted. So I think there's a recognition, and particularly when we talk about HER2, that being able to get 1+ and 2+, I'm going to say stably expressing samples is difficult, because a lot of cancers, not just those breast cancers with HER2, but a lot of cancers are heterogeneous. So you'll know firsthand, Richard, the futility of finding what you think's a good control material and then cutting through. And because of the heterogeneity, the question then is this a heterogeneous piece of tissue, or has my assay suddenly dropped off, as an example? So they recognise that labs are struggling for these, and they struggle for some of those rare mutation samples. And so the next best thing is being able to use these cell lines as a quality control. I should stress, Richard, that as a quality control, that's the limit of cell lines. They can tell you that the assays worked appropriately. I think the cells need to stay in lane. Tissue's really important still. Tissue's invaluable for validating assays, for troubleshooting in the laboratory, and so on and so forth. Really all they're doing is alleviating those pressures in the labs. And as I say, I think these external quality assurance groups recognize that, and I'd like to think CAP would as well. But we make sure that our customers know the limitations of the cell lines. They are, literally a quality control for the test and nothing more. There they have to consider the tissue for sure. Okay,
well, thank you, Colin. Those are the questions that I have. As I said, I have reviewed several sets of these slides, and I find the immunoreactivity very consistent, very easy to read. And I think the availability of ranges of immunoreactivity going from 0 negative to 1+ to 2+ to 3+ robust is critically important for the pathologist who's looking at these slides, making sure that the testing or the assay is working well in their labs. And as you and I know, most immunohistochemistry is qualitative. We simply just need a positive or negative result. But that's not the case for these biomarkers that are being used to identify targeted treatment for patients. And in this era of personalized medicine, laboratories need to make sure that their testing is accurate and is producing the correct result for that patient. And I think these control cell lines will be a game changer in my opinion. So thank you very much. I've enjoyed our discussion. It was nice to learn a little bit more about the Histocyte control cell lines. So thank you very much for allowing me to participate.
You're welcome.
I would like to thank you both, Colin and Richard, for sharing your expertise and time today in this discussion on Histocyte Laboratories cell line controls. For anyone who has questions on this discussion and material, please reach out to Newcomers Supply by phone or email, and we'll be happy to help. Thank you again for joining us.